Hi, everyone, and welcome. I'm Dr. Mary Imboden, and I'm going to talk to you all today about cardiopulmonary exercise testing and how the measurements that we obtain from these tests can inform clinical decisions and exercise programming. I am a cardiovascular and lifestyle behavior researcher by training, as well as a clinical exercise physiologist. And up until January of this year, I was the chair of the kinesiology department at George Fox, but recently switched roles, and I'm now the principal research scientist at Providence's Center for Cardiovascular Analytics, Research, and Data Science. In this role, I am specifically focused on helping clinicians understand the benefit of movement in prognosis of disease, and I'll share a few of these examples with you today. Let's get started. And really, we should start by defining cardiorespiratory fitness, which is the measure that can be obtained from cardiopulmonary exercise testing, as well as many other really important measures. This measure, though, we obtain from a test and really refers to the capacity of the circulatory and respiratory systems to supply oxygen to the skeletal muscle for energy production needed during exercise and physical activity. We commonly measure cardiorespiratory fitness as maximal oxygen consumption, or VO2 max, as you'll refer to it. And what you're seeing here is the Fick equation. And the Fick equation is VO2 is equal to Q, or cardiac output, times our AVO2 difference. Cardiac output, or the Q there, is going to be our central component of the equation. And then AVO2 difference is going to be the peripheral component. And when we break this down even further, we see that cardiac output is actually made up of our heart rate, which is our beats per minute, times our stroke volume, or how much we're getting out with each beat. Now, stroke volume can be broken down even more into our end diastolic volume, how much blood we're bringing into the heart during diastole, minus our end systolic volume, how much blood is left in the heart after the ejection phase. So what you're seeing in this image here, this pressure volume curve, is that with exercise, we actually increase our end diastolic volume, which then allows us to pump more blood out to fuel that exercise. Now, that's going to be our central component, like I said. And what we see, just as we just shared with that image there, is that from rest to exercise, our stroke volume significantly increases. So does our heart rate, which then ultimately increases our cardiac output. Now, look at the difference, though, between max exercise in a normal, healthy individual compared to max exercise in an elite athlete. What we're seeing there now is that the main difference is going to be their maximal stroke volume. So their heart is more efficient, it's able to bring more blood in, and then as a result, pump out more blood with each beat, ultimately increasing that cardiac output from a range of 20 to 25 to a range of 30 to 35, driving our VO2 max in athletes way up. And if you look at heart rate actually stays the same or might even slightly decrease in elite athletes. And the decrease is really a result of that extra time that's needed to fill the heart and just be more efficient. I also want you now to compare max exercise of this normal healthy individual, again, to the individual that has cardiovascular disease. With cardiovascular disease, we see that the heart is no longer efficient, right? There's actually dysfunction of the heart. And so we see a lower cardiac output. Heart rate varies depending on disease state, and stroke volume is going to be really low. Okay. Now, sometimes what we'll see on an electrocardiogram, which is really, really interesting to me, is that we see hypertrophy. And we'll see this hypertrophy of the left ventricle in both disease hearts, left ventricle hypertrophy, and we'll see it in athletes. And with athletes, it's a stronger muscle, right? That's able to then pump more out, so stronger contraction. But with the disease state, what we're seeing is like this actual, it's had to like almost compensate in a way because it's not either able to bring enough blood in, or it's compensated and we just started to have hypertrophy as a result of just really working hard against the pressure it has to overcome. And so when we think about and we see this on an electrocardiogram, we have to take into consideration physical activity status and other disease symptoms that are there. And obviously, if you see an athlete versus someone with cardiovascular disease, there's a lot of, there's not a lot of similarities, right? When we're thinking about clinical measures. So it's quite clear which one would be disease versus an athlete heart. And here's what you're seeing, right? So in heart failure specifically, heart failure is one of like the key symptoms of heart failure is exercise intolerance. And with both heart failure with reduced ejection fraction, meaning we're not getting the percent of blood that's pumped or brought in, the percent that we're pumping out is not to kind of the normal threshold. And then heart failure with preserved ejection fraction, it's getting to that percentage, but we're not even bringing enough in. So the percentage is kind of flawed, right? Both experience this reduced stroke volume as a result of lower preload coming in, so lower filling amount. And what do we have here? We have a much lower stroke volume. And if stroke volume is a part of cardiac output, which is a part of VO2 max, it's no wonder that these patients are having severely declined functional capacity, limiting their exercise ability, which then further exacerbates their disease and the cycle of it. Let's turn now to that peripheral component, our AVO2 difference. So our arteriovenous oxygen difference is the measure of the amount of oxygen taken up from the blood by our tissues. Okay, so if we think of it as how much oxygen is in our blood on the arterial side versus how much oxygen is in our blood on the venous side returning to the heart. So on the arterial side, we always, always, always want it to be 20 milliliters of oxygen per 100 milliliters of blood, and that's shouldn't change. But on the venous side is going to change depending on how much oxygen we need to do that activity that we're currently in. So we need less oxygen to fuel our muscles when we're just sitting or lying down or sleeping versus how much we need when we're up and running around, right? And so the actual difference is going to reflect that. And that's what you're seeing here. At rest, we typically have 20 milliliters of oxygen per 100 milliliters of blood on the arterial side, but then less is extracted into the muscles. And so on the venous side, we have 15 to 16 milliliters of oxygen per 100 milliliters of blood coming back to the heart. So the muscles extracted, or all different cells of the body, extracted 4 to 5 milliliters of oxygen per 100 milliliters of blood, which is our AVO2 difference. Now, if you put that 4 to 5 with our heart rate at rest and our stroke volume at rest, and we're using that for our calculation, our resting VO2 is going to be ultimately lower than with vigorous exercise. And what you're seeing here is 20 milliliters of oxygen per 100 milliliters of blood, again, on the arterial side. That's good. That's what we want to see. But on the venous side, now we've extracted more oxygen from the blood to be used to create ATP. And so we only have 5 milliliters of oxygen per 100 milliliters of blood coming back to the heart. So we've extracted 15 milliliters of oxygen per 100 milliliters of blood during vigorous exercise. And so that's what now our AVO2 difference is. And if we're multiplying that by our higher heart rate and higher stroke volume during vigorous exercise, again, our VO2 is increasing and higher during this type of activity. Now, depending on your athletic status, I would say, some people can move that number, that AVO2 difference at max exercise, from 15 to maybe 17, 18. So not a huge difference. It's really the driving difference between normal recreationally active individuals versus elite athletes is going to be the change or difference in stroke volume. So athletes having a much higher stroke volume at max exercise than just normal recreationally active or than sedentary individuals. Okay, and let's put some numbers to it to help you all out. So this would be rest, okay? So in this example, resting heart rate, 60 beats per minute, resting stroke volume, a normal resting stroke volume could be around 70 milliliters per beat. And then resting AVO2 difference, 5 milliliters of oxygen per 100 milliliters of blood. Okay, pretty textbook. Now, with that, we do our calculations and we see that our resting VO2 is around 210 milliliters per minute. And this is an absolute value. And that comes out to, we typically represent absolute values in liters per minute for some reason. So it's 0.21 liters per minute. Now, if we wanted to make it a relative value, which may be what you are more familiar with when it comes to your own VO2 max, you would divide that 210 milliliters per minute by your weight in kilograms. And that would be your relative VO2 relative to you, because it's your body weight you're putting into this equation now. And that would be resting VO2, relative resting VO2. Okay, now if we have someone whose max heart rate is 180 beats per minute and their stroke volume at max is 140 milliliters per beat, again, pretty normal, maybe a little bit on the more active side, and their max AVO2 difference is 15 milliliters of oxygen per 100 milliliters of blood, we're seeing, you know, these are going to be greater numbers, right? So we are at max effort and the VO2 max is coming in at 3.78 liters per minute. Okay. Now, again, if you wanted to make this a relative number, you would divide that 3,780 milliliters per minute by your body weight in kilograms to get your relative VO2. I should mention that the absolute people that just have greater body surface area, greater body size, put another way, are going to have a higher absolute VO2 as a result. So dividing by our body weight in kilograms actually gives us a better indication of fitness level in many cases. And just one more to see the difference between maybe a active individual with that last example to a elite athlete. Now we see that that max stroke volume increased from 140 to 180, okay? Heart rate stayed the same. And we do see maybe a slight increase in our AVO2 difference, meaning that the elite athlete's body is like, I'm going to be able to extract more oxygen out and use that to fuel this exercise. So going from 15 to maybe 18 at tops, okay? We never extract all full 20 milliliters of oxygen. So what we see with that equation is a higher VO2 at 5.83 liters per minute at max effort. So that's great, all really important. And when we think about how we measure that number, though, there are multiple ways to do so. And there's sort of a hierarchy. So I'm going to start with indirect methods. And what you're seeing here is going to be data from maximal exercise testing without cardiopulmonary exercise testing measurements, meaning we are having someone go to what they are telling us is their max, but we're not actually assessing any gases in this. So the gold standard method is going to be cardiopulmonary exercise testing with gas analysis, right? But when we don't have those really expensive systems present to us, we can do a max exercise test and take them to their age predicted max heart rate or their reported max and use the information from that test, like speed and grade on a treadmill test or maximal wattage on a cycle test, to then predict VO2 max. And there are some protocols that have been validated now where we actually can use exercise duration, how long they actually performed the exercise test in the equation to determine VO2 max. One thing I will say is that these equations do come with some error. So the Bruce equation that you're seeing, which is a very common test used in exercise physiology, used in clinic, has someone perform exercise on a treadmill, and we actually can use from their stage protocol time that the individual performed the test in seconds. Now, you do have to follow this protocol exactly, right? You can't, so the protocol specifically is 3 minutes at stage 1, which is 1.7 miles per hour, 10% grade, 3 minutes at stage 2, 2.5 miles per hour at 12% grade, 3 minutes at stage 3, 3.4 miles per hour at 14% grade, and so on, right? Because if you alter that at all, like you only do 2 minutes at stage 1, this now duration you can't use. So the validation is following the protocol exactly, putting the time into this equation in seconds. And with that, there's going to be a lot of differences from someone who gets to 9 minutes on the protocol, female, let's say, to the next female that does it and only gets 9 minutes. There's still some difference. And so the standard error that's been found is 3.22 mLs per kg per minute, meaning that it'd be more accurately to say to someone, your VO2, yes, it was measured here today. Like if we do this calculation, it's measured at, let's just say 30 milliliters per kilogram per minute. But really, to be more accurate, we would say it falls between 26.78 to 33.22 mLs per kg per minute. Okay, so plus or minus this value here. So there's error, right? And 3.22 is not nothing, right? 3.22 milliliters per kilogram per minute is almost 1 MET. And if you know anything about METs, if you don't know MET's a way to almost like understand intensity of activity. So if we prescribe activity and we say you should be performing an activity at 4 METs, really for that person, that could be if their max is 5, that's almost, if they're off by 3.22 and 3.5 equals 1 MET, that could be, a full, like, we're at our max versus we're at 80% of our max, right? So you just have to be careful with those errors in mind. Another way that we can assess VO2 max through an indirect method is actually using submaximal exercise testing without gas analysis. And in this assessment, an individual is performing an exercise at submaximal levels. And just in case you need an example of this, say my maximal wattage on the bike is 200 watts. And I might perform a submaximal exercise test then at 140 watts and have measurements taken, like heart rate at that level, blood pressure at that level. And then what we do here is we take, let's say, heart rate at 140 watts, and we extrapolate it to what my max is estimated to be. So if my max heart rate at 140 is 160, or I'm sorry, if my heart rate at 140 is 160, and then I extrapolate to my age predicted maximal heart rate, which let's say is 190, we go up there, and then from there, we draw a line down and we predict maximal workload. Okay, so if this sounds really difficult to you, it's because it is, and there's a lot of estimation and prediction in this method. It also assumes that heart rate max is uniform for a given age. So someone who's 30, it's saying, if we're using 220 minus your age, it's saying everyone that's 30 has a max heart rate of 190, which we just know is not to be correct. And we know that there's a high standard error of the estimate of age predicted max heart rate of 10 to 15 beats per minute. This ultimately leads to some maximal exercise tests having error of 10 to 15%. All of that to say, if you don't have the equipment to do a maximal exercise test, or the time really, or let's say it's not actually safe for an individual to perform a maximal exercise test in your clinic. You might perform a submaximal exercise test. Now you don't have to take them to those max levels where there could be symptoms that develop. And if you follow ACSM's guidelines for exercise testing, you might know that individuals that are at high risk of cardiovascular disease, we actually have a physician present when we're doing a stress test or any cardiopulmonary exercise test, right? Where we're taking them to max. Mm-hmm. And as a result, if they come to the PT clinic and you don't have their cardiologist or physician there, you might say, okay, it's safe to perform a submax test and try to get this information on your general fitness level, but we can't perform a max test. And that's ultimately what you're doing when it comes to 6-minute walk test and sit to stand. You're performing submaximal level exercise and then using that information to guide you in your decisions and your exercise plan. So with field tests, like the 6-minute walk test, like the sit to stand, these are great ways to predict cardiorespiratory fitness in a larger group, or when we don't have equipment like cardiopulmonary exercise testing, metabolic cart, or even don't want to perform exercise on a treadmill. It also gives us a clear indication of, how do these people feel when they're walking for this amount of time, or do they have to stop and catch their breath, or maybe there's something else that's limiting them, and that's the reason they came to PT, right? So that information can be captured in these assessments too. There's also strong association with many of these, like 6-minute walk tests and sit to stand, with risk of frailty. The 1.5-mile run, if you haven't done this assessment, really it's running 1.5 miles as quickly as possible. And then the time from that test is used to predict VO2 max. So again, if you haven't done it, you can go out to the track at George Fox and run 1.5 miles and then use your time and compare it to this chart here. Now, if you are a student that went to George Fox in the kinesiology department, you probably performed this 6 times. And so if you're looking for someone to help you understand this assessment better, I'm sure they would be happy to help. The 6-minute walk test, though, is going to be one that you use more often in clinic. And this test is a very common functional assessment, whether you're testing people with cardiovascular disease, cancer, respiratory disease, and it's simple. All you need is a 100-foot hallway or longer, some cones to kind of indicate where the turnaround points are. And the test specifically is going to measure the distance that a patient can quickly walk on a flat, hard surface in 6 minutes. And the important instruction to give to patients is that they get to select the intensity. The amount of times that I've done this test with clinical populations, they usually are looking for guidance from you on, so how quickly should I walk? And they get to decide what's comfortable for them. You want them to go as quickly as they can in that 6 minutes without running, but letting them know if they need to stop and rest during the test, that is okay. One thing we do see with the 6-minute walk test that I want to make you all aware of is a learning effect. And so sometimes when they're kind of looking for you for advice in that first one, and then they get it down and they understand what is being asked of them, they usually perform about 7% better on their second test. And as I mentioned, commonly used in clinical patients, so those with heart disease or lung disease. And we actually see that these thresholds here, so less than 350 meters, is associated with poor COPD prognosis. Less than 345 meters is associated with poor cardiovascular disease prognosis. And these tests commonly are used pre surgery or let's just say, like physician intervention, right? And post. And so the goal being that we want to see improvements in 6-minute walk test or any functional assessment after they've had a surgery or intervention. The sit to stand test, this is another field test that is quick and easy to use. And in this test, patients are instructed to sit and stand as quickly as they can from a chair with their arms crossed over their chest. And it either is for 30 seconds, 1 minute, or there's a set amount of time. The 30 seconds and 1 minute is are the most commonly used time for this assessment. And the 1 minute sit to stand is going to be correlated strongly with 6-minute walk test. So a lot of times the 1 minute sit to stand is used to predict VO2 max, whereas the shorter version, like the 30-second sit to stand, it's more commonly used to assess frailty. So assessing strength, risk of sarcopenia. Big thing here, you want a sturdy chair of standard height. No armrests should be used. And you should have someone kind of spotting the individual. You know, placing it against a wall is great, but if the chair has any like movement side to side or potentially going with the patient forward, we want to make sure someone's there to kind of help that individual stay safe. Finally, there's non-exercise prediction equations. And the non-exercise prediction equations, you know, do come with a lot of error. In these assessments, I should say, we use measurements that are commonly assessed in clinical settings like age, gender, BMI, body composition, heart rate, physical activity, smoking status. And these measures are actually put into a prediction equation. And obviously that comes with a lot of error, right? So someone of the same age and gender with a similar BMI can have very different VO2 maxes. And not all of these equations, I should note, not all of these measurements, I should note, are in every single equation. Researchers have really tried to simplify them because if it's more simple, it means people will use it more. But with that comes error. And so what you're seeing here is standard error of the estimate of 3 to 7 mLs per kg per minute. And that, again, that's not nothing. That's could be upwards of 2 METs. So what I do like about these, though, is that if this is in the physician's chart or the patient's chart, right? So Epic, these systems can actually pull data into an equation, calculate it for the physician, and let's say it's calculated low, it actually could be flagged and the physician might notice it more. And then as a result, speak to the patient about their VO2 and the importance of exercise, right? So there might be more opportunity for conversation, even though there's a lot of error with it. It does make it very, very simple and open up opportunity to talk about the importance of physical activity and exercise with patients. Finally, we'll get to the gold standard. So cardiopulmonary exercise testing. And I actually will be meeting with some students to record a cardiopulmonary exercise test, taking you from how do we actually calibrate the equipment all the way through the entire test. So what measurements are we looking at? What are we taking throughout the test? And I do believe Dr. Brummett is going to ask you to perform one of these and practice with a partner or two. So that recording will be really important to watch and understand how to perform it on the equipment in the clinic. Specifically, though, cardiopulmonary exercise test is the gold standard because it provides a thorough assessment of exercise capacity, and specifically looking at the integration of the pulmonary, cardiovascular, muscular, and cellular oxidative systems. And because it's measuring gas exchange, it provides the most accurate and thorough assessment of VO2 max, so maximal oxygen utilization. but also assesses ventilation, carbon dioxide output, respiratory exchange ratio, which is a measure of, are we actually at maximal effort? Heart rate, oxygen pulse, our ventilatory efficiency, our anaerobic threshold, or our lactate threshold, as well as many others. And like I said, a lot of these measures are being used in clinical decision making. Specifically, as one example, we see VO2 max combined with ventilatory efficiency. Those two measures in a quick snapshot for physicians to see, will this person who's on the transplant list actually have good outcomes from their transplant? And that's all based off research. So if someone's VO2 is low and their ventilatory efficiency is abnormal, they actually are predicted to have worse outcomes from the transplant, or potentially not see the benefits that other people do from a heart transplant, right? So anyway, those measurements are used in many different ways. So indications for cardiopulmonary exercise testing, let's just say there's many different reasons to do so. In a clinical setting, it may be used to evaluate exercise tolerance, or maybe more appropriately stated, exercise intolerance, as is commonly seen with heart failure, valve disease, or other cardiac conditions. It's used to evaluate patients with cardiovascular disease, respiratory disease, to see how they are progressing, or when their symptoms show up. It's used to develop exercise prescription. The ACSM recommends that patients entering cardiac rehab, for instance, perform a cardiopulmonary exercise test to safely prescribe exercise. So taking all of the data from the cardiopulmonary exercise testing and using that to write a very safe and beneficial exercise plan for that patient that is signed off by a cardiologist. We also perform cardiopulmonary exercise testing in athletes to more accurately prescribe training to benefit performance, as it does provide a direct measurement of functional capacity and provides measures of ventilatory efficiency at different workloads and anaerobic threshold, which are really important for training. And as mentioned with other types of tests, cardiopulmonary exercise testing can be used to evaluate patients prior to surgery to determine risk of surgery and benefit of the surgery in these patients. And what I'm seeing at the hospital, again, are many physicians including a post-operative test to determine changes in function after receiving surgery. So one study in particular is looking at patients that are receiving a transthoracic aortic valve replacement and looking at how the surgery improves function in patients. So they'll have a patient perform the 6-minute walk test, a gait speed test prior to surgery, and then after surgery as well. And what we're seeing is that in general, the baseline test is predicting readmission rate or mortality. However, we're also seeing that the replacement is actually improving function. So we're seeing improvements in 6-minute walk tests. We're seeing improvements in gait speed in patients. And some patients that were not ambulatory at all are now able to perform the test. So that's really exciting from a research standpoint. The other thing that I would just say there is that, I guess why I'm so excited about it, is that the device is not just helping the patient sit in bed, but we're actually seeing that the device is helping patients move and perform activities of daily living, which is important for patient independence and quality of life, right? So VO2 max, many different reasons. The last one there, disability determination. There's actually guidance that VO2 max under a certain level is eligibility criteria for receiving workers' compensation. So it shows up everywhere, really, and used in so many different ways and in so many different populations. So how is gas exchange measured? We see under steady state conditions, VO2 and VCO2, or oxygen consumption and carbon dioxide output measured at the mouth. So when someone's wearing a metabolic mask, those are equivalent to oxygen utilization and carbon dioxide production occurring in the cell. So it is thought that external respiration equals internal respiration. The cardiopulmonary exercise test, wearing that mask that then is hooked up to and connected to gas analyzers, measuring gas mixtures with each breath, it's measuring fractions of oxygen, carbon dioxide, and expired air volume or flow, and calculates then oxygen consumption, carbon dioxide output, and ventilation from these things. Now, a few things to consider. The mode that is selected for the test will impact the results. One of the measures that we commonly use, we always use to assess max effort with a cardiopulmonary exercise test, is our respiratory exchange ratio. And really, most people would agree that anything over 1.1 for our respiratory exchange ratio equals max effort. However, we do see that some people can be 1.1, some people can be 1.2, some people can be 1.3, right? And so that's really important to consider. If someone's 1.1 and we're saying that's criteria for max effort, but they could have gone to 1.3, we might see very small changes in their VO2 as a result of that. We also see that the mode of exercise will impact when we get to that number, right? And it'll impact our VO2 as a result. So in individuals that are not trained on a cycle, so they're not exercising and using a cycle ergometer regularly, they're going to typically perform 10 to 20% lower in their VO2 on a cycle than if they were to perform the test on a treadmill. And the reason for that is that most people are more comfortable and more familiar with walking and activity that would be performed on a treadmill versus cycling. The other reason for that is with the treadmill, we're using, if you think about the exercise that we're doing on a treadmill, walking with a grade or running, we're using all muscle groups. Versus the cycle, we might be limited in the muscle groups that we're using, and therefore brings down our VO2 as well. Okay, so there's also many other pros and cons of the cycle versus treadmill test. Some people, we can't do a treadmill test for. And so therefore we need to perform a cycle test. Cycle tests are going to be more safe. There's less noise, which does help with the blood pressure measurement. However, like I said, lower VO2 max. The selection of the protocol also does matter. And when we choose a protocol for a patient or a client coming in, we need to make sure that the protocol that's selected provides enough time to collect all measurements during each stage of the test. So if we have a 2-minute stage, we need to get heart rate, blood pressure, RP responses, electrocardiogram interpretation during those 2 minutes. If it's a 3-minute stage, we have a little bit more time. Okay. We also have to choose a protocol based on the participant's fitness and health status. And so if we have a protocol that does really, really large jumps in workload between stages, that might not be appropriate for someone who's less fit or has cardiovascular disease issues, right? And so the Bruce protocol, for instance, which jumps 2.5, 3 METs between stages, that really might not be appropriate for patients that are experiencing complications from underlying cardiovascular disease or just sedentary individuals in general. The ideal duration of an exercise test is 8 to 12 minutes. When we get above 15 minutes, really we start to bore our patients, right? And so the subject might stop because of boredom, discomfort, or local fatigue, especially when we're asking them to wear this tight-fitting mask for a while. That can actually just be discomfort of, wearing the mask that they're stopping as the reason. And tests less than 6 minutes, really, that's not enough time to observe responses. So, you got to you really need to know the patient and how they're coming in. What was their physical activity status before they are going through this test to know, what is the right protocol for them. So usually what I do, just as, resource for all of you, is I'll have patients fill out a health history questionnaire, which includes questions around behavior, like physical activity, like the medications that they're on, and if they're taking those medications regularly, any previous surgeries, or any current painful sites, to know, okay, I'm going to use that information from the health history to guide my decision on what protocol to select. And then from there is the capability to actually start on the Bruce protocol and realize, wow, we're getting this person really close to their age predicted max heart rate way too fast. And so from there, kind of adjust according to the protocol, or adjust the protocol according to what you're seeing in the patient that day, because you could be wrong. The Bruce protocol is one of the most commonly used protocols out there. Like I mentioned, there are really large stage increments in this protocol, so 2 to 3 METs between stages. It's a standard protocol, so when you follow it, the first stage is 1.7, 10% grade, 3 minutes. And then you go to the next stage for 3 minutes, and then the next one. It really may not be optimal for older adults, individuals with underlying disease, because of those really big jumps in intensity, to really get a good, clear indication of what their VO2 is. Here's an example of that. So let's say someone is just fine at 2.5, 12% grade. And then all of a sudden you bump them up to the next stage and they're at 3.4, 14% grade, and they're hanging on for 12 seconds, right? Well, they technically got to that speed and grade. They technically got to that next stage, but they didn't really work through even a full minute of that stage to get a good idea of what their blood pressure is, heart rate is at that workload, because the heart rate at 12 seconds into another stage is still adjusting for that increase in intensity. Additionally, when someone has underlying disease, really big jumps can be very detrimental, or just a risk of an event happening, right? Your body is almost shocked, I just went from this, now I'm here, and you're expecting me to work there. Can my body and my heart, my lungs actually keep up and quickly compensate, really, to the new demand that's being placed on them? The Balky protocol, this is it's an older protocol, but you still see it a lot, like the Aerobic Center longitudinal study, which is a big study. Lots and lots of tests have been done with this study. They use the Balky protocol, specifically a modified one, but it's to determine peak VO2, specifically in individuals that aren't as fit. So it was at first created as a clinical test to determine peak VO2 in cardiac patients, but we do see it often used in older adults or individuals with other underlying conditions. With this one, the Balky protocol specifically utilizes a constant walking speed of 3.3 miles per hour. And it starts at 0% grade and then increases to 2% grade after the first minute, and then continues to make a 1% increase in grade every minute. Like I said, modified versions are available. So some modified versions might be they just start at 3 miles per hour and do 1% grade every minute. So very similar, but just small modifications. And that was based off of using different populations, where we see maybe in women, 3 miles per hour with the differences or changes in grade led to a better result, right? So modified versions of the Balky, there's lots of different ones out there. And then we're seeing more and more ramp protocols being used. What I really, really like about ramp protocols is that they allow for more uniform gas exchange and hemodynamic response. So this image that you're seeing, each stair in the one on the left is basically, it's bigger, and meaning like you're having a greater change in intensity or workload between stages. So each stair is a stage. Whereas the ramp test, what you're seeing is smaller little stairs, but at the same time frame. So after, let's say, 3 minutes, you're at the same level as the stair in the graded test. So you're just doing smaller changes, let's say every 20 seconds to get to the same level at 3 minutes. And then you do smaller changes to get to the same level at 6 minutes, as you see with the graded test. So it really does allow for the body to kind of just adapt and compensate a little bit easier for more uniform gas exchange. Okay, and just to define it, ramp protocols are characterized by a gradual increase in work rate, evenly distributed within each minute of the stage. So, as I mentioned, Dr. Brummett is going to want you all to perform an exercise test, or that's my understanding. And so this is the sheet that I typically use. So every minute I record heart rate, rating of perceived exertion. So how hard does the individual on the treadmill or bike feel like they're working, and respiratory exchange ratio. Then every stage, so depending on the test you're doing, this printout here is using the Bruce protocol as an example. So in this case, every 3 minutes, I would be getting blood pressure. Now, with this, it's important to think about how long it's going to take you to actually get blood pressure on someone who's exercising. So if you haven't done this before, I usually say start trying to get the measurement at the 2-minute mark in the stage. That gives you a full minute to get the blood pressure on someone. And then once they start running, it's really not, it's okay, I should say, to not worry about blood pressure. So usually in the Bruce protocol, that's around stage 4 or minute 10. And really it's just because there's a lot of artifact, a lot of noise. You're probably not going to get a good blood pressure on someone. The other thing that this sheet allows is notes. So you can provide some notes on any arrhythmias that you see. If the individual reports any symptoms, hopefully not, but like I'm starting to feel lightheaded, we'd probably stop the test in this case, but you would want to write what minute that lightheadedness kind of started to come on. And then really important, you want to continue to monitor after exercise. So getting heart rate and blood pressure immediately after, especially if they started running, we want to get blood pressure immediately after to see what their max blood pressure is, because it will still be elevated. And then continue to monitor for a few minutes after. And then we would collect the reason for stopping the test. Was it localized leg fatigue? Was it overall fatigue, which is what we hope with a true max test? With the protocol selection, the decision there really does kind of reflect what is the patient's, what is the participant's exercise status, what is their health status. For most individuals in the class here, I would probably recommend the Bruce protocol or a ramp protocol. Now, in the medical science building, in the fall last year, so 2023 fall, we actually had cross-country runners come in. And the protocol that they selected was 6 miles per hour for a warm-up, let's say. And then they increased the speed to about 75% of threshold pace. And then from there, they increased speed by 2 miles per hour and 2% grade every 3 minutes. Okay. So this assessment was used in cross-country runners because our cross-country team are really, really fit, and we still want the test to only last them 8 to 12 minutes. So we need something that's going to be, causing fatigue in these runners that still gets them to max within 8 to 12 minutes. That wouldn't happen with the Bruce protocol. It wouldn't happen for sure with the bulky protocol, right? So we are selecting a ramp test that's specific to that population and really specific to each runner, because every runner that came in had a different threshold pace. I'm going to recommend, just so you guys get familiar with the Bruce protocol, that you do the Bruce protocol for your practice session. Okay, and as you guys are going through the testing, these are some of the measurements that we can obtain from a cardiopulmonary exercise test. So most are non-invasive. They're all being collected through the metabolic mass being hooked up to the gas analyzers, or from just the treadmill in general, right? So what is the workload? What's the speed and grade? What's the patient or participant reporting when it comes to symptoms like shortness of breath, fatigue, any chest pain? Hopefully not. But all of these measures can then be used to guide our exercise planning, our decisions on whether it's safe for that person to be in the PT clinic versus maybe needing to be seen by a cardiologist if they haven't yet, or a pulmonologist. Now, we also can do measures of lactate, and that would be more invasive. Maybe you've been seeing, I know I follow a lot of professional runners, and with their training, they're doing a lot of lactate pricks. So they're getting lactate at some of their workouts to understand kind of, are they at threshold when they're completing these? Okay, so these will be some things to look for when you're doing your exercise test. What's your heart rate at different workloads? What is your electrocardiogram response? So for some patients, like, they can go further on a test, but we're seeing in their electrocardiogram that they're starting to experience symptoms of ischemia, or what we call ST depression, on their electrocardiogram, indicating like it might be time to call it, right? It's not like soon, it's not going to be safe for these people to exercise. That gives us a lot of information when we go to write the exercise prescription, because we don't want them to have low oxygen to the heart, right? During exercise, we want it to be comfortable for them. We obviously don't want any complications. And so when we write the exercise prescription, we're going to take the information from the test and say, at this workload, they started to experience cardiac ischemia. And so we're going to write an exercise program that's 10% lower in intensity than where they were at during that time in the test, right? So lots of information to guide our exercise planning. And in the next screencast, I'm going to actually start to talk through these measures and their clinical role, as well as sort of what things we should be looking for to advance our knowledge of this individual's benefits to exercise. So talk soon.